Do you subscribe to every medical journal? Do you like reading the medical literature every morning with your coffee? No? Well, you don't have to make me feel like such a giant nerd for the things that I like, but if you just want a quick update, let's talk about the most interesting papers from the last year. Welcome back to First 10 EM. Like in the video that went up yesterday, this is a recording of a talk that I gave at the amazing North York General Emergency Medicine Update Conference. Slightly different than the normal format here, but I think chock full of interesting information. So let's just jump right in. Okay. It's time for a rapid review of what's new and interesting in the medical literature. 9 papers in about 15 minutes. These rapid reviews are perfect for the ADHD mind, and so I love them. But let's be honest, science has a ton of nuance, and you really just can't cover it in this format. So for each topic today, I'm going to give you the headline news, and then I'm going to try to give you 1 or 2 bits of nuance to at least think about, to mull over, and then I'll give you my own personal bottom line. But if any of these papers catch your interest, I have full write-ups with a bunch of links. Check out first10em.com. Jumping right in, one huge practice change this year was the use of steroids in community-acquired pneumonia. The big trial was COD. It's a multi-center RCT comparing steroids to placebo in 800 ICU patients with community-acquired pneumonia. And the headline news was there was a significant decrease in mortality, 6% versus 12%. That is about as good as it gets. The nuance here? Well, the most important bit of nuance in my mind is that we had an almost identical study published 1 year before, the ESCAPE trial, with 600 ICU patients randomized steroid versus placebo, and that trial was negative. And I think this is a really interesting bias in medicine. Everybody's talking about the positive study. Nobody talks about the negative study, but that's just not how science works. Now, luckily for us, ESCAPE was statistically negative, but the point estimate was consistent with about a 2% improvement in mortality, so I think these trials might be telling us the same thing. The other bit of nuance is that both of these trials excluded influenza, and the available evidence so far, it's not very good evidence, but the available evidence so far suggests potentially increased mortality with steroids in influenza. So bottom line, I think this is practice changing, but be very careful about indication creep. This is critically ill ICU patients. We know that steroids have lots of adverse events, and so we shouldn't be using them in the healthier patients going to the floor for now, and be careful about influenza. The other really big infectious disease trial last year was looking at sepsis, and there's been this question ever since Many Rivers and the Surviving Sepsis campaign, exactly how much fluids do these patients need? So the CLOVERS trial was a big RCT, multi-center, 1,500 adult patients with sepsis, and they were comparing a restrictive and a liberal fluid strategy. The exact algorithms are a little complex, but if you had markers of poor perfusion, hypotension, tachycardia, high lactate, in one group they suggested fluid boluses, and in the other they suggested early vasopressors. And the headline news was that mortality was identical. So liberal fluids, restricted, it just doesn't seem to matter. Now, there's a ton of nuance about this paper, and there's debates everywhere that you can really get into if you're interested. But I think the key issue in my mind to think about is that research patients are often monitored better than our standard patients. Now, that's not going to make a difference at all in the vasopressor group because monitoring in the ICU is fantastic. But the big mistake we tend to make in sepsis is we stick these borderline patients into ward beds where nobody's checking them just because they happen to get a little bit better after a fluid bolus. But we know that the effects of a fluid bolus are temporary, and so then these patients drop their pressure 2 or 3 hours later, but nobody's keeping a close eye on them. So outside of the research setting, if I am concerned about a patient, I tend to lean towards the vasopressor, not because I think the vasopressor is necessarily better in and of itself, but because I think this patient warrants an ICU bed and the vasopressor guarantees that they get it. So bottom line, this is a negative trial, so it's hard to say that it's practice changing, but I think it's one of the trials this year that is worth reading for yourself because there might be a lot of small details in there that could inform your judgment. And I think what this trial really says is that judgment matters. Now, in critical care, one of our favorite topics to debate is intubation techniques, and we had a big trial this year comparing video and direct laryngoscopies. The device trial, pragmatic open-label multi-center RCT, 1,400 patients, and the headline news I'm sure everybody has said, in terms of first-pass success, their primary outcome, video destroyed direct. Not even close, 85% versus 71%. But the nuance? Well, first-pass success is a surrogate outcome. Yeah, it's associated with things like hypoxia and complications. But what we really care about are those real adverse events. Your patient doesn't care if you intubate them on the first or the second attempt if their SAT stayed at 100 the entire time. And this trial was big enough that it probably shouldn't have used a surrogate outcome. And all the real-world events, desaturation, peri-intubation arrest, everything that we care about was identical in this study. So my bottom line, despite being a statistically positive study, I think this study actually shows that clinical outcomes are identical whether you use video or direct laryngoscopy. But I don't think you need science to know that video is better if it's available to you. If you're teaching, you have to use video. Otherwise, there's no way you can tell what your students are doing. But even when I'm intubating myself, it's so helpful to have the RTs or the nurses or the other docs in the room be able to see what's happening. They can help me suction, they can do laryngeal manipulation, or they can be prepared for the backup plan if they see me struggling a little bit. So I don't think you need science to show you that video is the way to go in the future. Now, in terms of intubation, I think the paper that's going to be a bigger practice changer is our first ever RCT of delayed sequence intubation. If that's a new term to anybody, delayed sequence intubation is essentially procedural sedation for the procedure of pre-oxygenation. It was designed for agitated patients who are not allowing you to pre-oxygenate them, and the idea is you give small doses of ketamine until they're calm, then you pre-oxygenate. That can be however you want, BiPAP, BVM, non-rebreather. And then only when you're comfortable with the patient's oxygen sats do you proceed with pushing the paralytic and going for intubation. The study this year was an RCT, single-center RCT, comparing DSI to RSI in adult trauma patients. And the headline news was that DSI was dramatically better. Peri-intubation hypoxia was 25% with RSI, 8% with DSI. First pass success was also significantly better. So nuance, this is our first RCT, so it is the best data we have, but it's a single-center unblinded trial. So it's not perfect data by any means. I think the biggest caveat with this trial is that they used this in the wrong population. Instead of just using it in patients with agitation, they used it on everybody. But there are a huge number of patients that don't need DSI. And so I think you can assume, perhaps, that the numbers would be even better if they just focused on the agitated subset that really need this approach. So my bottom line, despite the fact that this is a single-center, unblinded trial, and those kind of trials should rarely change your practice, I do think that this is practice changing. I think everybody needs to have DSI in their tool belt at this point. I don't think the data is strong enough for you to be using it routinely, but I gotta say, after having done this a number of times, it is so much easier to prepare for intubation and position a patient when they're chill on ketamine, and so I have been using this technique more and more often myself. Let's follow that up with some even lower quality data, but I think, again, another potential practice changer. Keppra or oh God, I'm just going to stick with Keppra. Keppra has been the go-to drug for status epilepticus for a number of reasons for a while. We could debate that if you want, but I think Keppra is a fine choice. One of the issues, though, is that like most of our anti-epileptics, it's still given as an infusion. It's a slightly quicker infusion than Dilantin for sure, but it's an infusion, and infusions aren't really ideal when you have a rapidly evolving critically ill patient like you do in status epilepticus. Apparently, though, there's a bunch of previous data from the manufacturer that says that Keppra can actually be pushed. And so one emergency department just made that their protocol. Instead of diluting in saline and giving the Keppra over 15 minutes, they just started giving it as an undiluted push, and they give us a prospective observational cohort. Their primary outcome was adverse events. It was 5%, but in these kind of trials, you have to use a pretty broad definition of adverse events, and we don't know. These might have occurred whether or not the drug was given. There were only 5 events in the trial that were considered significant. If you look just at the actively seizing patient, 80% were seizure-free when they were reassessed, which is a tremendous rate if these patients were truly in status. And so the headline news here appears to be that keppra is relatively safe when used as a push rather than an infusion. Now, nuance, this is a single-center observational trial. It's a small trial. We cannot say that keppra is definitively safe as a push, but on the other hand, without a control group, we don't really know that any of these adverse events were actually caused by the push rather than, just the fact that this patient's having an ongoing seizure. And so keppra could be even safer than this data suggests. My bottom line, really in my head, there's two very different types of seizure patients. If you have an active, ongoing, tonic-clonic seizure, true status epilepticus, those patients have really bad outcomes, and I think this data is enough for me to start pushing keppra in those patients. But simple seizures, or even those ones that are technically status, they didn't quite come back to their baseline and had a second seizure, I think in those patients, I'm still using a standard infusion over 15 minutes. All right, another small, imperfect trial, but I think practice changing for some people. I like this. This year, we're proving that you don't have to have massive, high-quality trials to actually have an impact on clinical practice. So in the crashing hypertensive pulmonary edema patient, SCAPE, sympathetic crashing pulmonary edema, probably most people in medicine have been underdosing nitroglycerin. In residency, I was taught you start an IV nitro drip at like 10 mics a minute. 50 was considered very high dose. Now that's been changing over the years, but this is the year that we got our very first RCT. Now it's an open label, single center RCT. There's only 52 patients in it. And what they did is they compared high to low dose nitro. The high dose was an IV bolus of 600 to 1,000 micrograms, and then an infusion started at 100 micrograms. Usual care was no bolus and a 20 to 40 microgram per minute starting dose of nitroglycerin. Headline news, the results were dramatically better with high-dose nitroglycerin. Symptom resolution at 6 hours was 65% versus 12%. Intubation was 19% versus 4%. Everything, admission, length of stay, major adverse cardiac event, everything was better in the high-dose group, and there was no hypotension in either group. Nuance, small, single-center, unblinded trial. These results sound too good to be true. They might be too good to be true. It would not take a lot at all to overturn this trial, although it does fit with the observational data we have so far. So despite being small, I think this is the best data that we have right now, and therefore I do think that it is, for the time being, practice changing. You should probably be using higher doses of nitroglycerin in these SCAPE patients than what most of us were taught, at least. Now, personally, I still give the bolus mostly sublingually just because it takes time to get an IV started. So I give 3 sprays or 1,200 micrograms of nitroglycerin sublingually while I'm getting the BiPAP mask on, and then just start my IV drip at 100 mics a minute, and I'm prepared to titrate that rapidly. This next trial, I think, might be the most misunderstood trial of the year. It's definitely not praxis changing, but it was worth going over because I think you will hear a lot about this, but I think a lot of the headline conclusions that you hear will be wrong. So this is the Interact 3 trial, big multi-center effort, 7,000 patients. And they call it a cluster RCT, but we'll get to that in a second. Essentially, this trial is looking at the impact of an intensive bundle of care in patients with head bleeds. So they had intensive targets for blood pressure, glucose, temperature, INR. And the headline news that you'll hear everywhere is that these patients had better functional outcomes, and so you should follow this regime. But that is not what this trial showed. The nuance, this is not an RCT. This is just a giant before and after trial, a very weak trial design, especially when it's not blinded and the outcomes of interest are subjective. Most importantly, none of the things that they were trying to change actually changed. The blood pressure in both groups was identical. It was a 3-point difference. Glucose only changed by 0.5. Temperature control was identical. Everything was the same. So how do you explain better outcomes in a trial where everything, all the treatments were identical? Well, there's only 2 options. Possibility number 1 is that this is pure bias in an unblinded trial. That is a possibility. The other possibility, and this is what I actually think is more likely, is that the intensive care group just got better nursing care. Because when you do all of the things described, you're going to have a nurse at the bedside more often, rather than being stuck in some dark corner of the ward. And high quality basic nursing is one thing that we know is absolutely essential in stroke care. And I think this is pretty important to say, even though I think I've heard people use this study to justify blood pressure targets in intracranial hemorrhage. That's just not right. This is a low quality before and after trial. We have 2 large RCTs of blood pressure control, Interact 2 and Attach 2, that show no benefit at all. This trial does not overrule those trials. The best trial out there says, the best data out there says you do not have to worry about blood pressure control in these patients. So my bottom line from this paper, I don't think that any of the individual intensive targets matter. And I think there's a lot of evidence previously that these intensive targets can cause a lot of harm. I think what matters is high quality nursing care, NPO until swallowing assessment, falls assessment, to get the bed rails up, head of the bed up to avoid aspiration. Focus on that, and I think you will get all of the benefits seen in this trial. All right, we can do this one quickly because I think everybody in medicine knows this by now. Contrast-induced nephropathy does not exist. It's not a thing. There's no evidence that contrast hurts kidneys, and actually, it's the exact opposite. There is a mountain of evidence that contrast has absolutely zero effect on kidneys, but it's such an important topic that I'll include one more paper that you can slip under your radiologist's door. This is a big propensity-matched observational trial, 15,000 patients. And I think the reason this trial is important is because it looks specifically at the patients that should be at the highest risk for contrast nephropathy, emergency department patients with new acute kidney injury. So everybody in this study had to have a creatinine at least 50% above their baseline. Exactly the kind of patients where you get endless phone calls and have to sign stupid ascientific consent forms. And then in this high-risk group of patients, they compared patients who had contrast to those who did not, propensity matched, and the odds ratio for renal failure was exactly 1. There was exactly no difference, and there was no difference in dialysis. Honestly, I don't think there's a ton of nuance here. Yes, this trial is not randomized. One observational trial is not definitive, but every single trial ever performed, every single trial with a control group, and we have hundreds of thousands of patients in these trials now, shows exactly zero harm from contrast. So the bottom line is very easy. There are many reasons to be thoughtful when ordering CT scans, but contrast and kidneys is just not one of them. If you work in a place where radiology still demands creatinine before giving an IV contrast, it's time to introduce them to the modern institution of science. We'll close out with maybe the lowest quality paper overall today, but I think the most important paper. What happens to patients who are forced to sleep overnight in the emergency department? What is the impact of boarding? And I think we already know this, but this year there was a big retrospective observational trial, 97 different emergency departments from France, and they focused on elderly patients. So we have 1,500 patients over the age of 75, and they compared patients who were transferred same day to the ward to those who spent the night in the emergency department. And headline news, there was a significant increase in mortality among patients boarded in the emergency department. 16% versus 11%, that's a 5% absolute increase in mortality. For every 20 patients who slept overnight in the emergency department, 1 died. A number needed to kill of 20. Now, of course, association, not causation. And there's a ton of nuance that needs to be added to a retrospective observational data. I actually think these numbers could be worse because usually you prioritize the sickest patients to get up to the ward faster, but that might depend on the system. Maybe some hospitals choose to keep sicker patients in the emergency department where they know there's a doctor present 24/7. So yeah, there's too many confounders for one study to be definitive. But it's not just one study. There's decades of data. Emergency departments are fantastic places, but they are not wards. We're not trained to, we're not designed to provide ongoing care to sick patients. The data is very clear. Outcomes are worse. Prolonged emergency department boarding kills patients. So my bottom line, unfortunately, as much as all of us would love to just put our heads down and look after the patient in front of us, we cannot afford to do that. We work in a system, and that system has much bigger impacts on our patients than we do individually. This is real. This is happening right now. We don't have a choice. We need to advocate. We need to agitate. We need to yell and scream at the administrators and the politicians who accept a system, who ignore a system that forces sick human beings to sleep in emergency department hallways for days at a time. That's just unacceptable. It's embarrassing. It's disgusting. And it needs to stop. And on that note, I will stop talking.